Okay, so in this video we are going to talk about the thyroid cancer and its classification. So let's begin from the thyroid cancer. So it is the most common cancer among all, and it is associated with post radiation and RET-PTC gene, and there are some other genes as well like BRAF, RAS and NTRK1 gene. So this is one of the questions, so I added it here. Then we have the lymphatic spread in it, and the most common site is lungs. Then microscopically what we can see, there are papille formations, seminal bodies, orphan nuclei and pseudo inclusion. We have the subtypes as well: follicular variant, diffuse sclerosing variant, then the tall cell variant where BRAF gene will be present. It is the more aggressive and metastasis will be more. And then we have the papillary microcarcinoma, which is less than 1 centimeter. The investigation of choice would be FNAC. The treatment will be total thyroidectomy plus removal of enlarged lymph node, and we can also do that is MRND, that is modified radical neck dissection. Just ignore my writing in this because I was writing very quickly. So let's see the follicular one. It is the endemic, the most common cause for endemic goiter. The RAS gene is involved, and the age group is 40 to 50 years. That is 50 to 60 years usually. So it is 20 to 30 years. Then we have the genes associated are like PAX8 gene, PPAR1 gene, translocation P10, P53. The spread will be hematogenous in this. The site would be bones, liver and lungs. There is a peculiarity about it that there are presence of Hurther cell. Hurther cell can also be seen in Hashimoto's as well. So there is capsular invasion, biopsy, vascular invasion. Then we can do the biopsy, and on biopsy we'll see all these invasions first, and then it is seen in iodine deficient areas, and it is the most common malignancy in long standard goiter. There is sudden increase in size of swelling. Actually these are the point which are like the short points, it is not like the proper notes, so I've just made the small notes, a small review of thyroid calcification. Hope you'll cooperate with this. So the most common site of metastasis is bones, thoracic ribs and pelvis. The investigation of choice is biopsy, and the treatment of choice is of course total thyroidectomy. Then we'll discuss the medullary thyroid cancer. The red gene is responsible. There are two types variant, that is the sporadic and the familial one. We'll discuss later. So the sporadic, the age would be 60 to 70 year, and the familial one will be in the younger age. That is also related to Men's syndrome. The spread will be lymphatic and hematogenous both, and the most common cytometastasis is liver. FNAC is done where we can see the polygonal serine amyloid stroma. Calcitonin is the best marker for this. Then we have the two types as I said, sporadic and the familial one. In sporadic we can see the unilateral, unicentric 60 to 70 years, familial bilateral multicentric indolent, and it has the best prognosis. I mean the familial one is having the best prognosis, but the sporadic one is bad. And then we have the man 2A, man 2B. Prophylactic thyroidectomy can be done, and investigation of choices of course FNAC, and the treatment of choice is total thyroidectomy plus lymph node dissection and ipsilateral MRND. So let's discuss the anaplastic cancer. We have the P53 gene association, that is the P53 mutation. So we can see the mutation in all of these genes. Then the age will be elderly, highly aggressive, firm, non-tender, cytokeratin is positive, globulin is not present. Extrathyroidal involvement will be there like esophagus, dysphagia, trachea, stridor, laryngeal nerve involved, and there will be hoarseness. Investigation of choice is FNAC, and treatment of choice for resectable one is the total thyroidectomy. For unresectable is tracheostomy. So thank you for watching the video. Hope you like this. Thank you.